Great. Good afternoon and good evening to everyone who's logged in online. I'm going to open up our webinar here with the introduction to both speakers and kind of lay out the discussion points that we'll get into here on a really fairly newer hot topic, I think, in the wake of publication of the option trial, and also just expanding use of concomitant procedures in EP and interventional. I'm Christopher Ellis. For those of you that don't know, I'm a professor of medicine at Vanderbilt. I've been doing left atrial appendage closure since about 2012. Initially with the lariat. It was actually my first tool that I got good with, and then, basically you kind of expanded into all the different devices now, and it's the really important thing to become, I think, super comfortable and consider yourself at least a bit of an expert on LAA closure before routinely, I think, considering concomitant procedures. But we'll go over a lot of, I think, some of the learning points that both Dr. Cuoco and myself have picked up over the years. My co-presenter is Dr. Frank Cuoco, Director of Cardiovascular Outreach and EP for HCA Trident in Charleston, South Carolina. So thank you very much, Frank. We've crossed paths and done a lot of these conferences together, so it should be a pretty lively discussion. The agenda, we're going to introduce first, I'll just briefly lay the groundwork for what's out there in terms of actual published data on concomitant procedure with Amulet from the eMERGE trial, or the eMERGE database, which is a post-approval cohort registry of real-world Amulet use. We'll discuss a little about patient selection for concomitant procedures. Which patients would you routinely want to consider that for, and which patients would you be more likely to stage the procedure as a separate procedure. We'll go over the best practice for discharge medication. I think that really is probably a bit of a hot topic and a sticking point, specifically with Amulet, due to the difference in the post-implant drug regimen label for the Amulet being DAPT, but really there's not a lot of data doing DAPT post-AF ablation as the primary preventer of embolic events post-ablation. So we'll have to get into that a bit. We'll talk about how we incorporate that into our practice, and then review a case, and then open up for a question and answer session. Here's a few things. Just the webinar is being recorded. It will be available later for on-demand viewing. You can submit questions anytime. They'll pop up in our presenter box that we can see. So as we go through, we'll sort of pick out the ones that are quite relevant to what we're discussing and try to open up those for more detailed discussion. There'll be a survey afterwards, and please provide input so we can make this better next time. So concomitant AF ablation and appendage closure with Amulet really is a fairly recent thing. I mean, I had not honestly done a whole lot of combined procedures with Amulet specifically outside of the option trial and an occasional, relatively rare Watchman 2.5 case that I would do where somebody really needed both somewhat urgently. I would say most of the cases now that we are doing these combined procedures on, they're kind of either patients who are sent for appendage closure and they really haven't had their AFib treated, or what we're seeing now is also a little bit more of a push from the younger lower Chad's VAS patient who wants the ablation but really doesn't want to be told afterwards that they have to continue anticoagulation indefinitely. The eMERGE registry for real-world Amulet use enrolled patients who had their device put in between August 2021 and December of 2023 in the NCDR registry. And we looked over those patients with patient characteristics, procedure details, discharge medications, how the appendage closure went early, mostly that's intraoperative, intraprocedural, and any major adverse events up to 45 days after implant. So the first thing you'll notice is there, out of 12,000 plus Amulet implant attempts, there really was a paucity of concomitant procedures. I mean, we'll get into this in just a bit, Frank, but I mean, probably at least 15% of patients that I'm ablating now are getting a concomitant closure, and it's an indicated closure. So, I would think, maybe there would be more like 3,000 patients with concomitant closure out of 12,000 implants. But here, we're only looking at 182, and that certainly reflects that this is the early Amulet experience. A lot of learning curve is baked into this, and probably a lot of newer implanters maybe not quite comfortable enough with the device to think about tagging it onto, at that time, which was mostly radio frequency ablation and cryoablation. This would really be prior to any PFA ablation. And I mean, I can't think of anything else in my career since 2009 that has been like a massive sweeping change in how I do something, like pulsed field ablation has done in the last year. So successful implants in the 182 attempted was 176, so pretty high implant success. 45-day follow-up data that was robust enough for analysis was in 127 patients. Versus, and we compare this just for, basically event rates to the patients who did not have catheter ablation done at the time of the Amulet implant. You can see there's a good chunk of patients who didn't really get in-window imaging for their follow-up visit. And I mean, probably a lot of those would be my patients, because I was really going more with the Catalyst protocol for most of my Amulets with a 90-day TEE for follow-up. In sort of a 3-month DAPT post-implant regimen. But for the data we do have, these are the characteristics. Patients with catheter ablation plus left atrial appendage closure tended to be a tad more persistent AFib, but with a lower CHA2DS2-VASc and a lower Hasbled score compared to the sort of more general commercially used Amulet population. Oddly, statistically, the appendages were smaller too. I don't know that makes a lot of sense, given more of the patients had persistent or permanent AFib listed as their arrhythmia diagnosis. Implant success was high in comparison to patients who did not have an ablation, really similar. Post-implant, that is to say on table, or up to 45-day post-peri-device leak, was pretty low rate, 2.9% in the combo arm and 2.1 in the catheter ablation arm. I don't think that there's enough values in the concomitant group there to make much of a statement that it's higher rate of leak, but certainly looked to be performing well at implant. Procedure time, obviously considerably longer, and this is accounted, I think, because of the technique of using radio frequency point-by-point RF, whether it's just PVI. You had a lot of persistent patients in here, so they may have had linear ablation or dot-by-dot posterior wall, typical flutter lines, etc. So the additional add-on to the total procedure time for the Amulet itself was basically an additional 80 minutes. Contrast volume used, obviously a little bit more. Well, actually, I guess it should be equivalent. I'm not sure. Statistically, this was not significantly different. And number of devices used, again, most of the cases were one device, perhaps with a repositioning or two, but not having to pull multiple devices very often. Event rates, peri-procedural, safety composite endpoint looked good. Any major adverse event, again, I wouldn't make much of this. It looked like concomitant procedures were safer than standalone Amulet, but I think that's just a statistical glitch. The ischemic stroke, systemic embolism, major vascular complication, and device embolization rates were low in both groups. Pericardial effusion rate was not significantly different, so that's good, because you do wonder, standalone Amulet has about a 2% effusion rate. I think that's pretty in line, but we're not adding a ton by placing the device in a freshly ablated atrium. Late pericardial effusion rate still in that 0.5% range. No significant differences really in mortality. The post-implant drug regimen, I think we'll get into a discussion and a Q&A on this. A reasonable number of patients, 80%, went home on systemic anticoagulation because it's really what you would do after an extensive radiofrequency ablation. And so, you know, the good thing is that didn't show any kind of uptick in substantial delayed effusion or pericardial effusion or major bleeding rates in the patients that had concomitant procedure. So, you know, that's the big flip. You can see the patients who have standalone amulet implanted, almost 90% of them are on either DAPT or single antiplatelet therapy, and only 11.8% went home on anticoagulant. The clinically relevant closure of the appendage was high, again, as we mentioned. I mean, there was only a 2% leak rate at implant, but at follow-up TEE, 94% less than a 3 millimeter leak, and almost 83% with no leak. Pretty comparable to the the standalone amulet implant group. So I think let me get Frank to chime in here. This is sort of background for what has been done in a small, registry pool. We'd like to get his experience and also have him open up a little on discussing patient selection for the concomitant procedure. Take it away, Frank.
Sure, Chris, thanks for having me. I really appreciate it. I like, I echo Chris's sentiments. I think in today's sort of modern ablation era with the use of PFA, I think this is where concomitant procedures really become much more practical and realistic. I think prior to this, where some radiofrequency or other cases were taking a significant amount of time, and additionally, there wasn't CMS reimbursement for concomitant. I think those were few and far between, but I certainly see a major shift in our practice. And Chris and I were actually talking offline prior to this webinar, and I think we both agreed we're doing a lot more concomitant than we even ever thought we would. I think we're finding now that there's many patients who want this. There's patients who I think really benefit from this, and it makes sense to do these procedures at the same time. I'll move on to the next slide because I just had some thoughts when I was asked to talk about patient selection. And I'm sure this will open up questions to everyone. And I'll sort of talk to you about the patients that I think about when I think about doing concomitant procedures. I mean, obviously, first and foremost, is it anyone and everyone? I think, as we progress, a lot of our AF patients are really thinking about both of these issues, and we're going to have to address this. But I think from a practical standpoint, from a workflow standpoint, we're not quite there for anyone and everyone yet. I do think about, though, patients that I really want to do one procedure on, what I consider like a one and done. For example, an elderly patient with persistent AFib who has a clear indication for a left atrial appendage closure, either a very high bleeding risk or a risk of bleeding. But they also probably have symptoms from their AF. And I actually had a patient yesterday that we did a concomitant on, a very robust 92-year-old. A little embarrassed to say she was 92, but she was spry as could be and very active and really felt poorly in AF. And she was breaking through with AF despite amiodarone, and she was clearly a fall risk and clearly not a good candidate for long-term anticoagulation. And her daughter was actually a lab tech at our hospital. We had a long discussion about what to do. And I think we all agreed that we wanted to close her left atrial appendage, but did we also want to do something else while we're there and try and make her feel better? And I had a very open and honest discussion with them and said, look, this may not work. There's a possibility that this AF may be difficult to manage, but we're going to be in doing this left atrial appendage closure. And with PFA, which is very time efficient and safe, we thought it was a reasonable option. And she actually came to the lab in atypical flutter, and we were able to terminate that. And we did her procedure and got an excellent result with the closure. So I think that's one patient who I think about. Also, I think about these long-standing persistent AFib patients who maybe, again, we would normally not consider for ablation prior to the PFA era, but they have a clear indication for left atrial appendage closure, and we say, okay, we're going to be in your left atrium. We can do, a pulmonary vein isolation, a posterior wall isolation, and additional substrate modification, all within a reasonable time frame. I also think about patients who perhaps were taking a last-ditch effort. I saw a patient today who's had a couple of different ablation procedures and a lot of substrate modification. And he came in with which is almost certainly a mitral isthmus flutter. And I explained to him today that he's had prior roof ablation. He's had prior anterior septal ablation. And when we ablate his mitral isthmus, there's a good chance we're going to incidentally isolate his left atrial appendage. So I said to him, and he also did not want to be on long-term anticoagulation. He had a lot of nuisance bruising and bleeding. Again, another patient that I said, okay, if we're going to bring you back, this is your third ablation. You're not really having AF. You're only having atypical flutter. I think this is reasonable. We can manage this, but we're probably going to wind up with isolation of your appendage at this time. So why don't we plan to close it at the same time? So we typically do that. And so those are the patients I'm really thinking about when I see them in clinic. Obviously, this patient preference is a big thing. I get asked over and over again, can we do these at the same time? Can we, or hey, I've heard about this closure device. Can you do that at the same time so I can come off anticoagulation? So those are just a few of the patients, obviously, that I think about. But these are coming up more and more frequently as we do more and more ablation, as we have a lower threshold with newer ablation technologies that are faster and safer. Chris, any comments on that?
Yeah, I was going to say, with the patient preference thing, I'm still kind of a stickler for, I want to see an indication for LAA on its own. And so, now it's not really, a bona fide indication change or covered for the sort of stable catalyst champion type patient. We do want to see the data from those studies, but option certainly gives you some hope that that's going to look quite favorable. So even without those patients, I'm still looking at, 15, 20% of my ablations being concomitant. I would think it's probably going to shoot to 50% by the time those trials come out. But I want to see, Ocean, some of the other trials on ILR monitoring and PRN DOAC, and see, are we necessarily like the CHADS VAS 2 and 3 patient, are they really better off with a device in the appendage or just waiting until they recur to make a decision on it? It's a tough call. We don't really know the answer to that, but I certainly think most of my CHADS VAS 5 or higher patients, like I would offer concomitant to the points that you just made. They're going to have very likely low left atrial appendage emptying velocity, fibrotic atria, compounding risk factors for bleeding, whether that's CKD or coronary disease, and require antiplatelet therapy and such long term. So those patients, I think, is pretty reasonable to consider the higher CHADS VAS patient coming in for an ablation, yes, concomitant, and then the patient's getting sent for LAA closure, where you think it doesn't add much, but they've really not had a shot at sinus rhythm with ablation. I would think that's pretty reasonable to offer to them. So yeah, I like all of that.
Yeah, I agree. I think these CHADS 2 VAS scores, certainly the 1s or 2s, that I think we're trying to figure out, do they really need anticoagulation after the ablation long term? But I agree, the higher risk scores, the 4s, the 5s, those are people that I'm not going to feel necessarily, especially if they were persistent AF in the past, that I'm going to feel comfortable telling them, hey, we're good to just take you off anticoagulation, 3 months after the ablation. I think we need to really, that's the person who I agree. I think those will be, as the data comes out, those will be people that probably will go straight to ablation and left atrial appendage closure. I think what is interesting though is, and I think maybe I'll bring this up later and I'll be curious to see, the question is though, when you do that ablation, especially with a device like Amulet, you know, what additional substrate modification are you going to do? How does the device interact with pulse field ablation technology going forward? Will it limit where you can ablate or what substrate you might want to ablate if it interacts? As you know, certain devices, if they're not fully endothelialized, can prevent delivery of pulse field ablation energy in certain locations in close proximity to the device. So I think about when I'm doing this, you know, what am I doing? To be honest with you, if I'm doing an ablation in a heavy persistent or a long-standing persistent or someone who's had multiple ablations, I mean, I isolate the appendage before I put in the device. I do, because I figured this is my one chance to do it relatively easily without a device in the way. So I think those are going to be things that we have to think about as we go forward as well.
Yeah, that will be an interesting evolving topic, is do you ablate and close or not? I mean, I can make a strong argument both ways. It's certainly it doesn't add much to go ahead and do it. I mean, I can't fault that probably, but the AMAZE trial was technically negative, and I mean, you know, we removed the appendage entirely. It was dead. So I'm not convinced it adds much, and probably in these patients that have got so much substrate, I mean, maybe it holds them a little better for a period of time, but I'm not sure that you have to do it on everybody. But I get your point. I mean, I know I saw at AF Symposium several folks doing the isolation prior to putting an Amulet or a Watchman in, and it certainly works good. I mean, it cups the ostium of the appendage pretty well, right? Or you can do it, I guess, in a basket if you need. But
yeah, no, anyhow. Absolutely. I think, I mean, it does work well, and I can tell you, I know it's durable, because when we bring patients back, a lot of times if I do isolate their appendage and I wasn't planning on doing a left atrial appendage closure, and I bring them back, we don't always remap them, although that would be interesting to remap them, but we always measure their emptying velocities, and they're almost always zero. So I think that's a good surrogate for
I hope it's not zero. If it's zero, that's a problem, right?
Yeah, but extremely low.
All right.
So I think next topic was, you know, what do we do about, discharging patients after concomitant? And obviously the big question is, you know, what's their medication regimen going to be? Yeah. Are we going to use, full dose anticoagulation with or without a baby aspirin for 3 or 6 months? What about half dose? I think a lot of people after these devices now are moving towards half dose anticoagulation. And is that safe after ablation? I think in the past with radiofrequency and cryo, where there was more injury to the endothelium, more risk, I think, for thrombus, I think a lot of us feel that maybe the risk is much, much lower with PFA, pulse field. And so maybe we don't need that full dose anticoagulation. And you brought up the topic earlier, Chris, about using dual antiplatelet therapy after the device. Is that going to be safe? And my gut is that it will be with pulse field. Obviously, we haven't proved it yet. For me, right, I can tell you anecdotally, I put them all on half dose anticoagulation with a baby aspirin. That's what I do. Okay. I'm not sure I have an answer, but I feel it's reasonable. Fortunately, we haven't seen any issues with that yet, but obviously that's all anecdotal. And again, like I said, the impact of the ablation modality you use, I think with radiofrequency or cryo, we know that these patients can have more events if you don't have them anticoagulated after. But with pulse field, I think that's it. And then I think, what about imaging? Should the imaging impact that? Are you going to do, imaging at 6 weeks and everything looks good? Do we just, do we stop that then and then we just go to aspirin, or do we just keep another 3 months? As you know, the Simplify trial is going on, and we're looking at regimens for this is in the Watchman population, but looking at aspirin only, or looking at aspirin and Plavix, or looking at just half dose OAC. So I think, will the timing of imaging impact your discharge medications as well. I think all those are considerations, and I think these are all things that are, to be determined, and we're hoping to figure out.
Yeah, I think for sure. Like my commercial, straightaway amulet implant, I've been pretty well sticking to sort of the catalyst regimen and been generally happy with that. The DAPT for 90 days, and then I get a TE at 90 days. If it looks good, we stop the Plavix. And it's pretty rare that I find a DRT there. If I do, then it's obviously the device has been in long enough. I don't have any problem to put them on anticoagulation. But typically, immediately post-implant, I don't. Some patients, the concomitant patients, and like the case I'm going to show, I did opt to go with the half-dose DOAC and aspirin, and that seemed to work quite well. So that may be a pretty reasonable in-between for the patients that you ablate, right?
Sure.
So, but I think when exactly to image these devices, it's different. I don't know. I feel like for Watchman, I have been underwhelmed by sort of the prevention of DRT theory of the Flex Pro. And I've pretty well gone back to, full anticoagulation for 90 days if people can tolerate it. So those patients, if I'm doing a concomitant with Watchman, I pretty much just leave them on full dose DOAC for 90 days and then image. But to be determined, as you said, there's a lot of moving parts on this. I guess the next topic would be, we've kind of touched on this a fair amount already, but how specifically would you incorporate this into your practice? And one thing I would throw out there, we were involved in this Med Axiom paper that's coming out, a white paper on sort of practices that do a lot of concomitants, what sort of how do they approach it? And one of the things that really did come up in there is like the role of the LAA coordinator and the nurse practitioners, and like who's kind of trying to coordinate, who schedules the case. Is it your ablation scheduler or is it your appendage scheduler? And how much time do you allow extra on Epic or whatever your scheduling platform is for these cases? Because I've had several. I had one, today I did 2 cases. One, I ablated him, older patient, but I'm going to bring him back for amulet later. Next, the other patient, I did concomitant. It's like an 87-year-old patient, like you talked about, PFA Watchman, did fine. But I've certainly had ones where I've gotten into it and, the ablation itself turned into a lot more than I thought. It was a longer case. And by the time I got to the appendage and was like, on top of it, this appendage is, brutal anatomy, I said, fine, I'm just going to bring him back. It's always a procedure that I think principally is a separate procedure and can be done staged. And there is no like demerit for, deciding in the middle of your day that you're not going to do them both at the same time. That is okay. Like you're not failing the test because you want to do both of these procedures, safely and effectively for the patient. And if you're putting that at risk in any way, I would say abandon the appendage, ablate and bring them back. This is because you're not going to ablate someone that's totally contraindicated to anticoagulation typically. So they're usually a patient that could at least go back on blood thinner for a while, and then you could close them later if necessary. So in my practice, at least incorporating this, it's a no-brainer for the people that have a strong indication for both parts of it. And I think my threshold to offer pulse field ablation as the ablation is a lot lower than it ever was with RF in patients that are primarily coming to get their appendage closed. What do you think about that, Frank?
So I think that, I agree with you. I think obviously the option, I agree. These are 2 distinct procedures and we can do them at the same time, but they're 2 distinct procedures. And I agree wholeheartedly that if you get into something that's hairy, or you're in a case, for example, and I'm going to bring up workflow in a second, but let's say you're in a case and you're just, you're doing the case with ice and you were planning to do the case with ice because you're doing a concomitant procedure and the ice images just aren't good. And like you said, it's a gnarly appendage. I think it's totally reasonable to stop and just say, look, we're going to bring you back and do this with TE imaging when I have the ability to do it right. Mm-hmm. If that's what you feel is necessary. I think for me, this is a workflow issue. And I can tell you, as you know, Chris, we have a high volume center. And right now, in order to accommodate this, we typically do Drew's transesophageal echocardiogram. We have not used a lot of ice. Now, as I'm going to mention here in a minute, we are embarking on incorporating more ice into our workflow because there's such a demand. And the issue is this: for us, we have a very high volume of cases, and like you said, time is a valuable commodity. So we have to figure out how to do them best. So we actually organize these on our left atrial appendage days. So we only do concomitant ablations on the same days that we're doing all of our left atrial appendage work, because from a workflow issue, one, it allows our left atrial appendage coordinator to be the primary scheduler, the primary person to handle these patients. And also to make sure that they're following them up, making sure they have their post-op imaging. It's a quality issue as well. But as for the workflow, we like to make sure that we have our cardiac anesthesiologists who do our imaging for these procedures available on those days. And they're not available every day of the week for us. They're extremely available. They're great. But I think most of us deal with this. Anesthesia is often a bottleneck for procedures for a lot of electrophysiologists and structural guys alike. And getting coverage for those cases with good quality imaging and doing that can be challenging. So right now, for example, what we will typically do is we'll do, 6 to 8 left atrial appendage. We have 2 rooms. We have 6 to 8 left atrial appendage closures with another 2 to 3 concomitants every day when we have a busy day. Plus, and so that's what we'll typically do, and we'll have the ability to use TEE for all of those cases. Now, like I said, because the demand is up, I have found that my number of concomitant slots is just inadequate. We might have 2 or 3 days a month that I do left atrial appendage closure where I load them up and we do these concomitants, but I need to do more than 6 to 8 concomitants a month. We need to do more than that. And so, because we just have the demand for it. And so now that's where I think you have to incorporate ice. In our case, we're using 4D ice now to help support these procedures. And so I think, that's the question. How do you incorporate it? And it's really about your workflow and how you do it to make it easier.
One thing that we are running into as we build out more concomitant cases, like 5 days a week, because we have cardiac anesthesia every day. So but it's possible that there's a concomitant like every day of the week. But the appendage closures themselves, the turnover in the PACU hold is a huge problem for us, like moving patients out of the lab. And now, so we've turned not only our appendage day, which is typically Mondays, but several of the other days in the week, we have to deal with where to get patients recovered after the procedure, because they're just coming out so much faster with PFA than they ever did with catheter ablation for AFib, that our AF ablation days have kind of gotten a little nuts. So I'd be curious just as to your method for closure, if you want to talk about that just for a sec, on vascular closure and your post, when you wake the patient up, where do they go? How long are they there? And when can they go home?
So that's a good question. Yeah. So I think, we currently do close all the groins. And I typically do, we're using a workstation, which is a large workstation. It's an 18 French cook workstation. So that way we don't have to exchange sheets between I say exchange sheets in the groin, and it's easier to retain access with less sort of bleeding and issues. So we will work through a 18 French workstation. Obviously we typically do the ablation first and the appendage at the end. And then we'll close that. I close that 18 French groin with a large Vascade, sort of obviously off label. We use, I'll usually just put a 9 or 10 French in that hole, and then I typically put a figure of 8 suture around that site, and then tie that figure of 8 tightly around the 2 sheaths in the right groin, and then close it with the 2 Vascades. and then I keep them on. We reverse everyone with protamine, and then and obviously we have access in the left groin as well. We close those, and then we typically keep them on 2 hours bed rest, and often, just because of the patients we're doing, and I think some of the patients I described, these older patients or high risk patients, usually one of them will stay overnight. The other two will go home after a couple hours, as long as there's no groin issue. But usually, for example, the 92-year-old, I kept her overnight. We didn't want to send her home at 7 or 8 p.m. Right. So, after a couple hours of bed rest. So, but I think that those are important issues. And I think, and I know I'm a big proponent of vascular closure. And I do think there's some novel vascular closure devices that are going to be coming out that are going to allow for more instantaneous closure, allow us to close 18 French holes with basically no bed rest. So I think that will help change the game.
Yeah, I mean, that would be a huge thing for us. I can say for sure, not being able to flip labs and having the roadblock of you got a patient awake on the table and you're just waiting until a spot opens up to get them out of the lab so you can get the next patient in. That we run into that a lot. It's a problem.
Yeah, prep and recovery space is a big issue, and I do think that vascular closure will make that better, but that's obviously another topic. But it's a workflow issue, and it's going to be a bigger issue as we move towards, ASC setting. I'm not sure that we're going to be doing concomitant procedures in the ASC setting right away, but I do think obviously eventually that'll come. Yeah,
I think it can. I mean, I think we've probably both seen enough cases that just are smooth and can get out of there. And how to sort of triage that on the front end is a tricky thing, though. But I think it can be done. Let me blow through this case real quick, just get some, show you a little bit of workflow on it, and then we can talk more and get the question and answer session going. Okay. So this was a patient I did maybe 9 months ago or so. 80-year-old man had been ablated by one of my partners with cryo balloon in 2022. Remote history of bypass and surgical AVR, and as we often see, a total failure of cardiac surgery. The left atrial appendage was not resected or clipped at the time of the open chest procedure, but he came back in to see me in sort of slow flutter with bifascicular block. He really doesn't want a pacemaker. He's got a portacath on the right, previous history of a right cerebral artery embolic event. So he had a embolic stroke with hemorrhagic conversion when he was on anticoagulation. When he came in, he was in this flutter in bifascicular block, but not on any anticoagulant at all. Chad's VAS score of 6. So he was sent to me by one of my partners for appendage closure and also AF ablation kind of redo procedure, and came into the lab in atypical flutter. So my workflow on PFA has largely, I've been trying to hybridize. I'm not comfortable enough yet that zero fluoro PFA, it's just been hard because I've had so many times where I'm using a system other than Opal and I have like ESI, and I can't really confidently say without looking on fluoro that I don't have a spline inverted. And it happens if the thing acts funny, you see more micro bubbles, and it flips a little bit on the map back and forth, and it just doesn't behave as fluid as, how when we were doing zero fluoro with Cardo and point by point, I mean, I literally didn't wear lead doing an AFib ablation for like a decade almost. So that's the one thing that I still am annoyed by with pulsed field, although the procedures are so much faster that it's not like you're wearing lead that long. But
Chris, it's doable. I promise you. I've done it.
It is. I know it is. And with left atrial ice, it definitely is. It's just, I still use, so I'm just saying this for like, what am I doing with my normal workflow? In this case, I had atypical flutter. I mapped with ESI. I had FARAWAVE for the PVI posterior wall portion. And then I'll do the SVC frequently on a persistent patient. In some paroxysmal patients. This tool works great for SVCs. And then he actually had presented, and we mapped, he had the atypical flutter on the anterior wall, kind of a mitral annular line was ablated with a Tactiflex. He did have a lot of fibrosis. I'm kind of surprised, honestly, that his appendage didn't isolate after the anterior line. My access site is the same as yours. I use the 18 French Cook check flow and 2.9 French short sheets, and I do them all on the right side. I haven't had any problems with that. I know some people like to go bilateral groins. I've generally avoided that just in terms of, I don't know, I think it's more of a hassle and maybe increases a little bit the chances of something bad happening. I don't know, but I think just for the workflow, I stay on the right. So this patient, we did the line, you can see the ice. Usually I use 2D ice from the right atrium, and as long as I've got a decent window through the septum, I can see everything pretty well. When someone's septum is way thick, it's tough sometimes to get good ice images of all 4 pulmonary veins. And I generally am a big proponent of pre-procedure imaging personally. I had a case recently where there was a sarcoid patient, and they had a diagnosis of secondary pulmonary hypertension, and nobody really had any clue that the guy's left superior pulmonary vein had been obliterated by extracardiac compression from lymph nodes. He also had a pericardial effusion at baseline and some other very interesting anatomy that I was well aware of going into it because I had a pre-procedure gated cardiac CT for anatomy. So I like to CT scan people. I don't know if you do that for every standalone appendage or just your concomitants, but I generally have such a wait time from when I see a patient in the office till I do it. There's lots of time to get a CT, and if they get it locally, that's fine as long as I get the images. Most of the time I try to encourage them to get it at our center because it's much easier to download on the day of the procedure. So anyway, we got the guy, got him back in sinus rhythm. Here is the appendage. So we get our baseline measurements, and it's kind of one of those, depends a little, but where that pulmonary artery was, I felt a little better about coming up a tad more proximal on the landing zone. And so that was kind of in the right upper panel on the 135, where you can see I'm measuring kind of from that pectinate up a little higher to the proximal side of the ridge. But this was relatively smooth. So the transition, I don't know about your general feeling, but I tend to go kind of mid-low on my transeptal stick. And with this, I will say with the 13 French Agilis, that is a hugely helpful improvement, I think, in terms of PFA workflow. And so I feel a lot more confident that I can stick where I want to go for the appendage closure primarily, and make the ablation quite smooth by utilizing the 13 French Agilis. Is a little bit like, I don't know that every place has them yet. It's fairly newer, but I would say it's definitely a better sheath for navigating and dealing with the lower transeptal site when you're trying to still get that right inferior vein ablated and not have to make some crazy, twisted up ball to try to get into the vein. I mean, I think it works great. So
that's a really good point, Chris. I mean, I think transeptal location and how it is depending on the ablation modality you're going to use. I think, that might actually impact what ablation modality what product I use in the future, because, obviously with larger focal catheters or focal PFA catheters, that may be less of an issue in terms of being more mid or higher with your stick, because you don't have a large, flower shaped form factor to deal with to get around the right inferior pulmonary vein. If you have a focal catheter, it's obviously still somewhat of an issue, but a little less so. And I agree. And I think, localizing where you're going to be and trying to figure that out. Most of the time we get away with kind of a mid slightly anterior stick with these concomitant procedures. But I agree, there's some gnarly appendages that you really need to be as low as possible. And that can make your ablation more challenging depending on what sheath you use.
Yeah, I try to optimize the transeptal a little bit more for the appendage than for the ablation, but because I feel like it's pretty, there's some wiggle room that you don't have to be like in the perfect spot for the ablation part, but it does make it a lot harder if you're in a bad spot for the appendage closure. So the transition from the sheath to, like, I don't know, I think it's a lot of large bore sheaths. You want to be very mindful of air embolism, ACT over 300 consistently. Really make sure you heparinize once you get access and get wires in, so you don't start the clot propagation cascade in any way on these cases. And I think one of the things too is, like, if you're planning on doing right atrial ablation, that is to say SVC isolation or typical flutter line or dealing with something else, do you like to finish up what you're doing in the left atrium, like do PBI, posterior wall, close the appendage and get out of the left, then deal with the right? Or do you do the veins, posterior wall, pull into the right atrium, go up to the SVC, do the SVC, maybe drop a flutter line, and then go back through the same hole back into the left atrium to place the amulet at the very end of the case? What's your approach on that?
My decision to do the CTI and SVC is usually made before the procedure. Obviously if I wasn't planning on doing it and they come back, that can throw a wrinkle in it, but I generally will do those first, Chris. So basically what I typically do, my workflow is to do the right atrial work first and then do the left atrial work and be done. So usually, for example, I obviously use a lot of Farapulse too. And so what I'll typically do is go in and, either make my right atrial map or make my right atrial map as I'm going, and I'll isolate the SVC and do the CTI first. And even if they're in a fib, I don't really have a problem doing the CTI first because I'll check for block afterwards on the way out. And I mean, with the techniques we have, and as you know, I'll be showing this in a live case next week at the PFA symposium. Getting block with PFA catheters in the CTI is not challenging. It's very straightforward, and the block is almost always achieved with first pass and durably. So I think my point is I'm willing to do that first, and then if they're, like I said, if they're in a fib and I can't check for block before I go over the left atrium, I'll check for block after they're in sinus rhythm. Because I do find that we convert a lot of people, as you saw in your case. I mean, these atypical flutters or even a fib with a lot of substrate modification, I've never seen so many conversions to sinus rhythm as I have since we've used PFA and done substrate modification.
I find that it's really great on the anterior wall flutters around the anterior side of the right superior pulmonary vein, where you can really press that thing up into, and that's a hard area in your Bachman's bundle to get with an RF catheter. And I've seen a number of those where they've had recurrent LA anterior wall flutter, and hitting that hard with PFA did the trick, and they had a pacemaker. I knew exactly what the AF burden was. And that was, I agree with you on that. So my question to you on this then is, if you're going to do right atrial ablation first, what's your transeptal puncture process? Have you already dropped a sheath into the LA and it's just sitting there on the sidelines, or are you using some kind of combined tool with the Agilis for transeptal?
So for me, I tend to use FaraDrive Connect. If it's an Opal case, I'll use FaraDrive Connect and I'll do that. And I've moved more towards Opal for these procedures. The only issue I have is that with, redo AFibs, if they're redo or you want to do some more extensive mapping, then I tend to use Cardo, and I'll make my map with the Octaray. Then I'll just put in the FaraDrive sheath and do that and then go transeptal across. So typically I'll use FaraDrive Connect. So that way I can go I just pull out the ablation catheter and then put the Connect dilator up. So that's usually been our workflow for that. I find myself leaning towards using Opal for these cases because it's easier. Not because in terms of that workflow, exactly what you're talking about. Because otherwise, then, like you said, you have to do a Baylis or some other system if you're using VersaCross or whatever you're using to cross, and then you got to switch back, or you have to pull back into the right atrium. It becomes a little bit of a challenge. Now, again, with these concomitant procedures, I usually have a workstation, so switching out sheaths is not as big a deal as long as you're not, I'm not talking about exchanging in the left atrium, but when you're not yet in the left atrium, exchanging a sheath through a workstation is pretty straightforward.
I do really like the idea of getting all of the ablation done before you close the appendage. And the big reason is, in my mind, let's say you work in the LA, you close the appendage, you go to the RA, and you just get some ridiculous flutter that you have to cardiovert the patient for, and you've already released your appendage closure device. It's really not an ideal situation. You would like, I think, to complete the procedure by closing the appendage, reversing anticoagulation, and taking out all the sheaths. So I tend to go, I'll go back and forth at will. I mean, I'll go left atrium, ablate, come to the RA, do the SVC. And then when I'm happy that everything's good and we're in sinus rhythm, then I mean, it's very easy to pop back through the hole. I mean, it's a huge,
no question.
It's a huge hole. It's like anything is going to drop through it. So it's not.
No,
hard.
yeah, crossing the septum is not an issue these days. I think back when we were all, with much less accurate tools and less experience with ice. I mean, now crossing back over the septum, I agree. And I do echo your sentiments, Chris. I found that, I've only had 2 devices acutely dislodged in my career. One was very early, and it was due to some very poor imaging and probably a bad decision to release the device. The second one, though, was a patient who actually we did an AV node ablation on after we did the left atrial appendage closure, and the patient had a very stable device position. And when we did the AV node ablation, they had a very long pause, and it changed the hemodynamics, I believe, in the atrium, and then the device sort of watermelon seated out of the atrium or out of the appendage. And I can tell you that, there was no question that was the timing of it, and that's what happened. There was a long pause, the atrium filled, and there was a large contraction and change. So I agree with you. I don't like to have to do a lot of changes in heart rate or things when you just have a fresh device. I mean, obviously, I think that's not going to be an issue later. But, I think, for me now, I agree. I do all my ablation before the implant, and then I do the implant, and I don't do any ablation after, or shocking or anything else.
Yep. This was just my wrap-up slide from that case. So I think you saw that it was nicely positioned on the tip of the PV ridge down to the mitral annulus, no overhanging, cavity on top of the disc. So really in a standalone case, that might be a patient that I would send home on single antiplatelet therapy, especially given his bleeding history. But I ended up opting to send him home on half-dose DOAC and baby aspirin. Just some key points here, and then we can do the Q&A. I think reminder, you want to master both of these procedures before you combine them. The indication for appendage closure has really not changed, and it can always be done staged, so don't feel bad about that. But when you do want to do it, I'd say mid-low transeptal is great, especially if you have, a sheath you feel comfortable in tight spaces with. Certainly, when you're doing the amulet portion, after we exchange to that, you could consider the steerable sheath. It helps optimize a little bit where to place the disc. But most cases, if your transeptal is spot on, you really don't need the steerable necessarily to be able to position there. But sometimes if you're really trying to set that disc right up on top of the ridge, steerable sheath can be helpful. Hopefully there'll be a next generation on that coming that should be an improvement. And then again, your typical post-implant drug regimen is just going to carry through that ablation healing period. I would say, I don't know what you're feeling on this. If you had somebody where you really wanted to minimize how long they're on anticoagulation post PFA, I've been just doing a month, and I haven't seen any issue. But I don't know. What do you think? But the recommendation is 2 to 3 months.
Yeah, I'll be honest. I think again, it depends on if we're talking concomitant or Chad's Vasc, what their Chad's Vasc is. I have stopped anticoagulation in patients 3 to 4 weeks after PFA with no issues. I'm not sure, and like I've said, I've had this conversation with many of the experts in our field, including Doctors Natali and Laccaretti and Reddy, and we just I don't think we've proven it yet, but I think a lot of us feel that this anticoagulation after the ablation may not be as important, as, at least from post-procedural risk standpoint. That being said, the patient may have high risk because of their Chad's too vast or recurrence issues. But I think, in terms of, causing injury to the endothelium and that resulting in an iatrogenic thrombus, I think that's just much less likely with PFA technology.
Yeah, agreed. So I was just looking through the Q&A box. There's one question, number 2 is kind of on this topic, just in the setting of the post-implant drug regimen, when you get to 45 days, if there is somebody who develops thrombus on their device, how do you generally treat that? Do you have a prescription for anticoagulation for a DRT at 6 weeks or beyond on an amulet? What would you recommend?
On the chat screen there, for some reason, the chat screen came up at the same time.
Yeah.
I apologize. So Chris, your question was, what do I do if there's a DRT?
Let's say you go through that first month up to 6 weeks or whatever on the anticoagulation. It's a high risk bleeder, transition to DAPT, but is your plan, but they show up and there's actually thrombus on the device. So they've developed thrombus despite anticoagulation in the early post-implant time window.
Yeah, fortunately, I've only had one case like that we had where we had anticoagulation, where we had a DRT on full dose anticoagulation on an amulet. And actually what we wound up doing was we wound up actually putting the patient, now this patient could tolerate it, fortunately, but we wound up putting him on BID to Xarelto, and did that, and the thrombus cleared, and the patient did fine. And then we were able to stop it, and fortunately we re-imaged them, and it did not recur. But yeah, no, that's a very tough scenario. Obviously this is the one scenario where we're trying to make things better and we possibly make them worse.
Right.
So
and I mean, I think to this point though, we don't feel that the ablation itself, unlike RFA, it probably doesn't promote DRT in any way. It doesn't seem. Whereas the inflammation, somebody who got like raging pericarditis after an RFA, and then you did a concomitant, you could imagine how that inflammation could be prothrombotic in that patient. But I haven't seen
absolutely.
Anything. Yeah. Now, question number 1. Yes, CMS has the combo procedure code. I haven't had any problems with insurance on concomitants. I don't know about your experience with that, but I haven't had any issue.
I've had 1 or 2 patients with particular insurance reject the left atrial appendage. Now, granted, these were more patient preference type issues where there wasn't really well documented bleeding. Obviously, a lot of these patients are Medicare patients, so that doesn't wind up being quite an issue in terms of prior authorization. Payment has not been an issue. And I do want to put an important note out there. There are some proposed increases to these DRGs, including concomitant, and I believe it's about 8% an increase for the hospital payment. Now, unfortunately, not for us. We kind of get, as physicians, as you know, we get the raw end of that deal. We still only get paid half for the left atrial appendage, and we still get paid full for the ablation, but only half the left atrial appendage. But the hospital is getting quite the reimbursement for this, and so the hospital really does make out well.
Yep. Couple last questions here, and then we'll wrap it up. Can you speak to the changes in appendage size pre and post? So this is the thing. I haven't really honestly seen much of an issue with that. And I do the pre-imaging, so I have the CT. I've got in mind the device size when I go in. And oftentimes I have TE baseline images before I ablate. So I size prior to ablation. But with the pulsed field, I haven't really honestly seen that much change in terms of the edema ridge question. What's your experience with that?
No, that's a great question. There is no question there is edema with PFA. I think it depends on what PFA you use too. Certain PFAs obviously create more heat and more thermal energy and can cause more edema. However, I agree with you. We typically, like for example, if the workflow is with a TE, we drop. My anesthesiologist does the TE prior to the ablation, takes measurements, and then after the ablation, we'll quickly check those measurements. I don't know that we've seen more than a change in 1 millimeter in any measurement, which I think is probably error of measurement potentially with a TE probe. But
Yep.
that, I think that's a really important point. It's something we need to think about and look at as we do more of these. And especially if you're going to ablate the appendage itself, if you're going to isolate the appendage itself, I do think that at least double checking your measurements before you go ahead and go, you might want to double check that.
Yep.
And also that may impact left atrial pressure as well. So you might want to note that as well.
Let's knock out these last couple and then wrap it up. So how to avoid late effusions with Amulet. That's a topic, mostly that I think we've investigated well with pre-imaging and not placing the lobe in a really thin transverse sinus or along the edge of a large pulsatile pulmonary artery. So that, that's a positioning issue. And sometimes you may switch devices. You may just not have a good place to put an Amulet. Fine. There's another device. Now, as far as post-implant drug regimen after a concomitant, if the appendage closure was more difficult. Now, I don't know. I mean, I don't know why half-dose DOAC versus full-dose DOAC would really make a difference in that scenario. I mean, I've generally not sent these patients home on DAPT anyway, so I'm probably going at least with some anticoagulant. But yes, if you had tons of recaptures and multiple devices and it was a tough case, maybe you had thrombus on the device or on the wires, you may opt that you would want to put the patient on full anticoagulation and just, do a careful echo the next morning, keep them overnight, and then, call and check on them carefully. And if they get through the first few, days without a problem, I think beyond a week, you're probably not going to get significant late effusion, but it's rare that can happen. But
Chris, I think your point is well taken. I mean, listen, if you have a tough implant, there's nothing wrong with keeping the patient.
Yeah, right.
There's nothing wrong, because I've seen in my experience that the late complications are typically not 4 or 5, 6 days. They're within 24, maybe 48 hours. And I think it's reasonable. And, some of these patients are frail and some of them, are not, or are from far away. I have no problem. Biting the bullet, keeping that patient, because that's what's right for the patient. I think ultimately you do what's right for the patient. And this is where I think it's good to follow a protocol. It's good to have a regimen, but at the end of the day, you're treating that individual patient, and that individual patient may not fit your standard protocol. And then you have to treat that individual patient.
Well, great. I think we'll probably wrap it up there. I appreciate everyone staying on this evening to hear our discussion and fire off some good questions. Good luck out there. Take care of the patients, get rid of all that AFib, and make sure you do the appendage closure with no leaks. Obviously that's a hot topic too. We'll be certainly happy, I think, to answer additional questions over email after, but we've run over our time a little bit here. So I think we'll wrap it up. And so on behalf of Frank Cuoco, myself, and Abbott Medical, we appreciate your engagement in this webinar. Thank you.
Thank you all for having us.